Okay, well, thank you to those of you who are joining us live. I see a couple of my residents on the Zoom call right now, but for those of you that don't know me, I'm Jennifer Villwock, and I'm on the faculty at the University of Kansas Medical Center in the Department of Otolaryngology, and I am one of the rhinologists there. And one of my main areas of interest actually is the sense of smell. And so I've always been a little bit fascinated by how under recognized the importance of it is, not only in our patients' daily lives, but also clinically. And I think it's a very interesting opportunity currently for all of us to get a little bit more excited in and invested about olfaction and how that impacts us, especially since that is something that has come to the forefront of the clinical signs for the coronavirus. And let's see, hopefully it'll let me advance my screen. So in terms of disclosures, our group does have a patent pending for aroma, which is one of our new smell testing methodologies, but I will not be discussing that today. And when we think about sense of smell, I think a lot of us know that it is important, and that's something that we see throughout not just the scientific literature, but also just literature. And so it's said, as you see here, that smell is important. It reminds a person of all the things he or she has been through. It's a sheath of memories and security. And, you know, similarly, smell oftentimes is linked to memory. And I think a lot of us have memories in the past where, you know, maybe you smell gingerbread and it takes you to family gatherings back from childhood. And so those things are all very important. And, you know, on a less sophisticated level, you know, it's also important for daily life, right? And knowing how to behave and interact in certain situations. So some people believe he who smelt it dealt it, while others are believers of he who denied it supplied it. So whichever group you fall into, you do know that smell is important. And you don't have to take it from me. You can certainly take it from Dr. Oz as well. And for a while, different smell tests were actually very popular, and he popularized a couple at-home items that could be used to potentially screen for Alzheimer's disease, which then, as you can imagine, made a lot of people very concerned if they were not able to smell some of those products. And for those of you who are unaware of what these these two sides of the same coin look like, this is actually the Nobel Prize. And this is Dr. Linda Buck and then also Dr. Richard Axel. And they actually won the Nobel Prize for Medicine and Physiology in 2004. And that was for their discovery of odorant receptors and the organization of the olfactory system. And so you can see that this has all been recently developed in the past 20 or 30 years. In fact, their foundational paper was only just recently published in 1991. And so when we think of, you know, scientific discoveries, this is something that olfaction has only recently come to the forefront. And the objectives for this talk are really to give an overview of the basics of olfaction, olfactory dysfunction itself, how this impacts sinonasal disorders, neurocognitive disorders. We'll talk a little bit about post-viral olfactory dysfunction as well, and then olfactory recovery and training. And so starting with some basics, I'm going to start with some cases, but of course I cannot ask people questions. So I will just kind of proceed through. But case number one is a 22-year-old Neanderthal, and he wants to know how his sense of smell compares to his human neighbors. And so the reason that I bring this case up is that olfaction actually is very important, not just from an activities of daily life perspective, but also evolutionarily. So olfaction, actually it has about 1,000 dedicated genes, 350 of which are still functional in humans. And it's about 1% of expressed genes, which is the largest known vertebrate gene family. And so what's happening here in these pictures is that there are some folks that did some fancy image analysis of the skull base of humans versus the skull base of Neanderthals. And overall, what they found is that the olfactory input structure, despite brains overall being the same size, is about 12% larger in humans. And they thought that this conferred a competitive advantage, whether it's for finding food, pheromone detection, etc. And so what actually you can maybe appreciate on the right-hand picture here for the Homo sapiens is that there was lateral expansion of the anterior cranial fossa, which enlarged the cribriform plate and the olfactory bulb, making sense because we were more highly valuing olfaction. And then also backwards retraction of the sphenoid and sella. So we could maybe guess that pituitary surgery maybe was easier for Neanderthals than humans based on this. But again, my main point here is just to emphasize how evolutionarily not only important, but conserved sense of smell is. And so why do we care about olfaction? Well, we know that it's important for food, right? It helps us tell us what's good to eat, what's not, hopefully avoiding some other things that are potentially toxic. And it's also important for safety, right? There's a smell that's impregnated with a natural gas so that we know if there's a gas leak. We can smell fire, those sorts of things. And then it's also important for marketing. And this goes back to the fact that so much of smell triggers memories. We're not the only people that know that. The branding people and the marketers know that as well. That's why there's consistent smells, you know, in the cookie shop or in the coffee shop, etc., because they want you to associate those experiences with good things and thus spend your money on their products. And we also know that smell is actually very important for our overall enjoyment of food. And the way that I explain it to my patients, and I think this very simple diagram is best, is that there are certain things that are hardwired outside of sense of smell. And so that's taste of the classic, you know, salty, sweet, bitter, you know, because typically even in my patients who have completely lost their sense of smell and can't really taste anything, if I were to give them, you know, just a straight up cube of sugar, they would be able to tell me it was sweet. Same with if I gave them, you know, a bunch of salt, they would be able to say that, yeah, something is salty, but they don't perceive any flavor because it's the combination of those hardwired signals through other pathways plus the aromas from their sense of smell that actually give them the true flavor of food. And there's two mechanisms by which odorants can get up to the olfactory epithelium and the olfactory bulb. So the first is what you see on the left-hand side, which is orthonasal, and that's typically what we think about in just people with unaltered anatomy, right? You're gonna smell something in, the odorant molecules are gonna get transported up to the olfactory areas. However, you can also get retronasal airflow as well, and that would be as you're masticating that piece of food, there's some odorant molecules that in a retrograde fashion go from the oropharynx up through the nasopharynx and present odorant molecules in that way as well. And there's all sorts of reasons for olfactory dysfunction itself, right? So he who shall not be named, right, doesn't really seem to have a lot going on in the nose area. Perhaps it's stenosed shut. So he might not have the best sense of smell, but there are also specific deficits in sense of smell. So for example, some people just cannot perceive garlic, but otherwise everything else is normal for them. And so when we think about what is required for a functioning olfactory system, you know, I always used to joke with people that the reason I like to learn about olfaction is because it's like the simplest. You know, all your other cranial nerves, there's synapsing and there's ganglia. But for cranial nerve 1, there's not a whole lot of that. It's just a straight projection, no ganglia. But it is still, you know, relatively complex. And so what you see illustrated here is that at the bottom of the screen, you know, you have your airflow, which is represented by these blue arrows, and then you have your odorant molecules, and the green things are odorant binding proteins. All of these things are required just to get the odorant to be physically presented to the olfactory receptor neurons or the olfactory sensory neurons. Those two things are synonyms. You also have a variety of supporting cells, which you see here. And then the axons of your olfactory receptor neurons actually then project into the olfactory bulb and subsequently higher cortical centers. And so what is the purpose of those olfactory binding proteins? Well, there's a layer of mucus that's lining the olfactory epithelium. And for the little odorant molecules to actually get to the olfactory receptor neurons, they have to somehow make it through the mucus. And so the thought is that the olfactory binding proteins, so they both bind but also solubilize hydrophobic odorant molecules into the hydrophilic olfactory mucus so that they can be effectively presented. And then on the flip side of that, as things are processed and they no longer need to continue to activate signal, it also allows them to be passed on in the mucus and processed. And so the mucus itself is typically about 60 microns thick. And as I mentioned, the odorants have to be soluble enough in the mucus to actually reach the receptors. As I mentioned, there is quite a few different cell types within the olfactory epithelium. And so you have your supporting or sustentacular cells, you have microvillar cells as well, Bowman's glands and ducts, and then also basal cells. And what's really important about the olfactory epithelium is that it does turn over every 40 to 60 days. And we know that it's from these basal and supporting cells through which you can get regeneration of some of the receptor neurons as well. And that's one of the reasons why, if you've lost your sense of smell, it's not necessarily something that's a permanent deficit as it would be if you had, for example, a spinal cord injury. There's also olfactory cilia. I'm not going to talk too much about them, but similar to in the GI system, they also help increase the surface area. But unlike other cilia, there's no Dynan arms. And then as we think about the next step in the process, which would be the olfactory receptors or neurons themselves, these are bipolar receptor neurons. And so as I mentioned before, they're direct projections into the nasal cavity without any intervening synapses. There's about 100 or so receptors, but because of the way they're organized, it allows them to recognize 10,000 different odors. And there's actually some very interesting literature that shows that humans who have been training their noses can actually sometimes be more accurate in the detection of odors than things like gas chromatography. And so the life cycle of these is about 60 days, 40 to 60 days, and they are continuously turning over. And then next we have the olfactory bulb, and it is actually organized into an inner and an outer layer, but for the purposes of this discussion, we'll talk about it as one. And so this is where the olfactory receptor neurons synapse with their postsynaptic nerves into glomeruli. And each area of the bulb receives most of its information from a certain region of the mucosa. And so to me, I'm a rhinologist, so I try not to think much about the ear. It's kind of like a black box for me. But as I was learning initially about this, I was like, oh no, this sounds an awful lot like the cochlea. But essentially it is arranged very similarly. And so some people have called it odorotopic or odotopic organization, very similar to what happens in the auditory system. And regeneration is possible. It is possible to establish new olfactory bulb connections. There is that preservation of spatial mapping, and this does require intact basal cells and stem cells. Every couple of years, that direct connection makes its way to CNN via these types of headlines, right? And so this is the reason why we always tell our patients, if you're going to be using nasal sinus irrigations, please always use previously boiled water that obviously has cooled off, or distilled water, just to ensure the cleanliness of what you're putting into your nose, because it is a direct connection. And there have been a couple of reports now, I think the most recent one was in Seattle not too long ago, of people actually suffering some very devastating neurologic consequences after irrigating with water contaminated with some amoebas. And so now we're going to transition a little bit more into, I think, what most of you probably care about, which is the how is olfactory dysfunction manifested. And one thing that I do think it's very important to note is that lack of awareness actually is very common. And so I see this more commonly in the research that we do. So some of the cohorts that we're currently testing are people with Alzheimer's disease and Parkinson's disease. and they will have very pronounced olfactory dysfunction on our testing. But when you give them, a questionnaire of olfactory dysfunction or other questionnaires asking them to rate how bad their sense of smell is, oftentimes they say that it's just fine. So they're completely unaware. And often lack of awareness occurs also in the elderly population. And so, I've tested elderly couples together, and the wife will be kind of like sassing her husband, being like, "Oh, he doesn't smell anything, and my sense of smell is better than it's ever been." And then you give them an objective test, and you're like, "Actually, both of you kind of don't have the best sense of smell." So a lot of the processing is unconscious, and it seems that perhaps there's a threshold before it becomes something that's consciously perceived. And so one of the goals then is to minimize the impact from a safety standpoint. And so making sure that if your patients do have objective dysfunction, that they're aware of that, because it has implications for food safety and home safety, among other things. I think it's also interesting that for some folks, their olfactory dysfunction is so pronounced and so important to them that they have written entire books on it that you can check out on Amazon or from the local library. They're not necessarily the best reviewed of books. I have not read them myself, but I just put this up here to illustrate again how important this is to so many people. And when we think about why is it that people are losing their sense of smell, so we see here that a lot of the etiologies are things that we would think about initially, right? So for ENTs, obviously sinonasal disease is something that we see very commonly, and we know that olfactory dysfunction is associated, with chronic sinusitis, whether it's with or without polyps, allergic rhinitis as well. Upper respiratory tract infections also have a very well described association with olfactory dysfunction. Idiopathic certainly is always a player. And then down the list, we have things like head trauma. And so that's kind of beyond the scope of what I'm going to talk about today. But certainly if you have significant head trauma and either you have direct injury to some of the higher cortical processing centers, or if you have shearing of the olfactory receptor neurons as they're coming down through the cribriform, that can result in a long-lasting and permanent olfactory dysfunction. Toxins, the one that I think most folks and our patients too are most aware of is the direct toxicity of applying zinc to the nasal mucosa, which used to be in one of the nasal Zicam formulations. And then there's also congenital causes as well. And when we think about the magnitude of the impact in patients with smell disorders, you can see, the whole host of things here. All right, so decreased enjoyment of food for sure. So some people will increase their food intake as a result, and some will decrease it. Some will actually over season their food in hopes of getting some sort of taste back. Difficulties in cooking, right? Because if you can't smell when something is adequately cooked, that's an option. Eating spoiled food. So it's thought that in older patients, especially, that their olfactory dysfunction may be something that contributes to higher levels of GI upset, GI distress, because they're not perceiving, spoiled or rotten food. And because of that, they're more likely to have issues with maintaining adequate nutrition or being admitted to the hospital even for dehydration and GI upset. A lot of people have a risk of failure to perceive fire or gas, which again is a very important safety consideration. And it's also important to note that for some folks, problems at work or with paid employment are very prominent for them as well. I mean, this isn't just people that work in the food industry or somewhere where, you would think that part of their job is their sense of smell. I've had patients who have come to me and said, this particular person, works in a business environment. And she said that, randomly throughout one day, she kept getting whiffs of something terrible. And then at the end of the day, she got home and her husband told her, that terrible thing was probably you because you smell super bad. And so she's like, God help the people that had to interact with me all day. So can have very significant impacts. And so Tales from the Trenches, this is just an example of from a couple of my clinics. I had one patient who said that at one point they had vacationed in Arizona after their initial smell loss, and they were going to enroll in one of my clinical trials, but only if going back to Arizona didn't fix their sense of smell. So they were actually willing to move to another geographic location away from family and friends and where they'd been their whole life, just in hopes of getting some return of olfactory function. Some patients literally have their husband or their significant other smell their armpits. I've had patients who also say they have to do things like change their baby's diapers compulsively because they just cannot tell if anything is going on there. And so as we think about one of the most common causes that we see in our practices as otolaryngologists, oftentimes it's this, right? It's somebody who has chronic sinusitis and they've been medically optimized, and now they want to know, will surgery fix my sense of smell? Or sometimes it's the kind of the same overall patient presentation, but maybe they've had surgery before and it didn't help, but will this one help? Or maybe they've had surgery, things got better, now they're worse. What's going to happen with sense of smell? And so we know that chronic rhinosinusitis and olfactory dysfunction are linked. And so, thinking about polyps, allergic rhinitis, your overall atopic and inflammatory burden. But we also know that those aren't the only reasons that people get olfactory dysfunction. And so where we try to intervene then is with medical management and with surgery. And there have been a couple of studies that have looked at this recently. And so this is a study of the comparative effectiveness of medical and surgical therapy on olfaction in CRS. And this was a prospective and multi-institutional study. The citation is there for you to see at the bottom left of the screen. And what the study population was 220 individuals with CRS, and olfaction was measured at baseline. And so it was measured with the BSIT, which is the brief version of the UPSIT, but also the SNOT and the RSDI as other quality of life metrics, and then comparison of surgery versus continued medical management. And they found a couple of interesting things. See if this will go. So if you were normosmic at baseline, you tended to remain normosmic. And so that's something that can be nice if patients have been reading horror stories or have heard from other folks that they had some sort of nose surgery and then lost their sense of smell. That typically should not occur. They found that overall baseline olfactory dysfunction, about 36% returned to normosmia. So not a huge amount, but some gains. But one of the things that I found important from this paper was that if there was prior sinus surgery, the olfactory gains tended to be less. And then there's also been a couple of other publications that I think are important to highlight here. So this one was another chemosensory function before and after multimodal treatment. And so what they found, and this was a smaller study of about 20 to 30 individuals, but what was found here was that multimodal treatment was helpful for olfaction, but not necessarily for sense of taste. And they found with FES and post-op antibiotics and oral steroids, about 42% had a significant improvement in olfaction, but about 53% did not. In that second paper, you see there improvement of olfactory function for quality of life. This was a slightly larger study of 89 individuals. And what they found was when they compared allergic rhinitis to chronic rhinosinusitis, they found actually that allergic rhinitis patients tended to improve less, even with what we would consider, optimal medical management. But they thought that this might be because the baseline olfactory dysfunction in that group was somewhat less to begin with. And if you've been reading anything in the CRS or sinus literature recently, you've definitely seen studies on the microbiome, and it appears to also have links to olfaction as well. And so there was a study of 67 healthy volunteers. And so 28 were normal, 29 were super smellers, and 10 were hyposmic. And what they found is that there were actually differences in the microbiome community composition, especially for the hyposmics. And so it is implicated that perhaps in some of these individuals, it's the microbiome. It's hard to know if it's correlative or causative, but there can be microbiome abnormalities in our patients with olfactory dysfunction as well. And that's just a graphical representation of the olfactory status and also microbiome community structure. All right, so our next case here is an older gentleman who, and this is a stock photo, so I had to make the case fit the photo, but this is an older gentleman who loves peanut butter on celery, but he's been noticing that he can't smell it as much now. And so he wants to know if this means he has Alzheimer's disease. And, this kind of harkens back to Dr. Oz telling people that they should all test their sense of smell with some products. And, if you can't, then maybe you have Alzheimer's disease. So this knowledge is certainly out there in the lay press and just among the general population. And so with that, we're going to talk a little bit more about olfaction and neurocognitive disorders. Let's skip this slide. And it is important to note that a few things. So number one, loss of sense of smell is considered part of the quote unquote normal aging process. And so typically as you age, kind of like, hearing loss, it's something that does occur with age. And so at the age of 80, like 80% of people have detectable olfactory dysfunction. At 65, it's 50% or more. And so it's not necessarily a pathologic finding. But there has been a lot of work that's been done, especially in Alzheimer's disease and mild cognitive impairment studies, trying to link olfaction with Alzheimer's disease. And in all the studies that have been done, there has always been a link between the two. So if you have a patient who's being worked up for Alzheimer's disease, you objectively test their sense of smell and it's spot on normal, probably do not have that process going on. And one of the reasons for this is that the beta amyloid plaques that are prominent in Alzheimer's disease, one of the earliest areas of deposition is actually within the olfactory bulb. And so there's very strong literature that suggests that initial deposition of these proteins in the olfactory bulb precedes the onset of clinical Alzheimer's disease by a number of years. And that's what this figure here that you see is displaying. It's actually showing areas of amyloid deposition, comparing someone with Alzheimer's disease with someone who is normally aging. And you can appreciate, yes, there's scattered depositions kind of everywhere, illustrated by the red, but some of the most concentrated hotspots there are in the area of the olfactory bulb. Thinking about neurocognition as well, we touched briefly on traumatic brain injury and dysfunction after traumatic brain injury. The incidence of this also is, pretty high. It can be anywhere from 22 to 57%, depends on the demographic of the study and the inclusion criteria, of course. But this is thought to be due either to nasal injury, right? So if we have some sort of acute injury, septal hematoma, massive amount of swelling, of course, that's going to mechanically prevent odorants from getting up to the olfactory areas. But you can also have olfactory nerve shearing. There can be cortical injury to the orbitofrontal area, which can be demonstrated subsequently by volume loss of the olfactory bulb and tract and the inferior frontal cortex. And they can be associated with executive function issues. And this makes sense from a neuroanatomical standpoint because the projections from the olfactory bulb are pretty widespread and include like the entorhinal cortex, the hippocampus. And so there's a lot of overlap in terms of where olfaction is processed and things like memory and executive function. And so what do we know about regain of function? So if we're looking at all cause olfactory dysfunction, you're typically going to do better if you're younger, if it's post-viral as opposed to related to a neurocognitive process, like Alzheimer's disease. And this can occur years after onset, or if it's a sinonasal etiology where we're able to actually treat the atopic components or the sinusitis and inflammation. And so now I wanted to talk a little bit more about the post-viral component. And this is going to become more and more prominent, I think, for us and certainly patients and questions that we may get in the era of COVID. So, you know, let's pretend someone's COVID positive and their sense of smell is decreased. What does that mean? And what do we do with that information? All right, because one of the questions is, okay, it's good that we noticed it. It's good that, you know, maybe this is what triggered the testing. And so now they know that they're positive and that, you know, they should self-isolate and protect their community. But overall, is it good or is it bad that they have olfactory dysfunction as a prominent component of their overall symptomatology? And so what we do know is that the overall prevalence of olfactory dysfunction with COVID-19, depending on the paper that you read, is anywhere from 80 to 98%. So it's there. And also it can be the presenting symptom. So the first symptom in 10 to 20% of individuals. And what can also be important here is that for a lot of people, congestion and other nasal complaints are absent. So it's just olfaction is impacted, but they feel like they're breathing fine, not having tons of rhinorrhea, etc. And so we've actually had some folks at our institution, you know, who have been treating patients and who got their COVID testing because they noticed their anosmia and that was their only symptom and were subsequently positive. And when I think about, well, is this good or is this bad? It makes me think back kind of to some of the pathophysiologic mechanisms by which viruses can impact the olfactory system. And so we know that it's strain and virus dependent. So even different strains of influenza have different levels of tropism for the olfactory system. What we do know about COVID is that it seems to be requiring a number of things for entry, but one of which is the ACE2 receptor. And so this one is actually expressed in the sustentacular cells, the horizontal basal cells, and Bowman's gland. So definitely expressed within the olfactory epithelium. And interestingly, interferon alpha is a driven upregulator of the receptor. So it's thought that if there's some, you know, the viral insult itself is causing some inflammation that then upregulates the ACE2 receptor and facilitates entry. There's a couple of other proteases and things that are thought to be required for sustained entry. And then subsequently, the mechanism of olfactory dysfunction is disruption of homeostasis and regeneration of the receptor neurons, or perhaps neuronal damage in the higher cortical centers. Of course, you know, these are all things that we're still trying to more precisely figure out, not only for diagnostic, but also for possible therapeutic purposes. And when we think about what does it mean, you know, for me, there's a couple of competing hypotheses based on what we know. So for example, perhaps you want to have prominent olfactory dysfunction as your first and maybe most severe symptom of this. Because if the reason for the olfactory dysfunction is that you're getting apoptosis at the level of either your olfactory epithelium or the olfactory receptor neurons, or even within the bulb, that might actually be a good thing, right? Because it's going to prevent further central nervous system spread. And so as there's increasing reports of people having neurologic sequelae from their viral infections, I think this is something that's important to be on our radars, right? And I think hopefully we'll have more information about this in the next several months as to if magnitude of olfactory dysfunction actually impacts disease course. And the long-term prognosis is unknown. At this point, I'm aware of only one paper that has enrolled people who had recovered from their acute illness to see what their olfactory function is. And for the majority of them, it was still decreased. But I think more evidence certainly is still needed. And that leads us kind of into the final topic here, which is olfactory recovery and training, because perhaps less so for the COVID folks, because I still have not seen a lot of them, but certainly for my other post-viral anosmia patients or my other patients that are having issues of unknown etiology or after other insults, they want to know like, like they know that they have this problem. So it's not that helpful for me to objectively diagnose it for them, but they want to know, okay, what can be done? Right? How do I help myself get better, or what can anyone do to help me get better? And there have been a couple of papers of note. So this one was from 2006, and this was, as you can see, an updated review of clinical olfaction. And basically, long story short, at that point in time, we have no effective treatment for the most common causes of olfactory loss. But then you fast forward a little bit to 2017, and then the evidence for olfactory training in treating patients with olfactory loss. Now, in the 10 or 11 intervening years between that first review and subsequent research, now we know that we do actually have a way to help people that have lost their sense of smell, and that is olfactory training, which we'll discuss here shortly. There are some other options that can be tried. So there have been some publications investigating the impact of budesonide rinses, even if you do an endoscopy and it's not terribly inflamed, that can be helpful as well. There was some older literature looking at modalities like oral zinc supplementation or alpha lipoic acid supplementation. And those are things that I still offer to my patients. I tell them that the evidence is, kind of equivocal in terms of how effective those might be. But if it's something that they would like to try, they're certainly welcome to do that. And so what is olfactory training? Well, it's something that has been done for a long time by people that rely on their sense of smell for their jobs, like sommeliers. And so that you can get actually these really fancy kits on Amazon. I think this one here is a couple $100, and it's for wine tasting. For those that are a little bit less sophisticated, perhaps, you can also do one for beer aromas. So these things exist. But for a lot of our patients, what I would recommend is not necessarily the couple $100 kit off of Amazon, but they can adhere to an olfactory training protocol. And so the citation that you see there at the bottom left is one of the original papers by Dr. Hummel and his group. And what they did is they investigated olfactory training in patients with olfactory loss. And these were primarily post-viral or idiopathic. And you train twice a day, and they were followed for 12 weeks, and they found improvement at about 30% with their threshold discrimination identification scores 10 points higher. And so your next question is probably like, all right, cool. What is olfactory training? So it's known exposure to known odorants, and like I said, twice a day. And what was initially picked because it was thought to represent the extremes of sense of smell, kind of like how salty, sweet, bitter, umami, etc., are the extremes of taste. And so a rose, not ode to koala, but eucalyptus. That's why I put that koala there. Clove, and then also lemon. And then, of course, we always want to know is more better. And so there was a follow-up study where instead of, smaller concentrations, they used much higher concentrations. and did the same olfactory training protocol, but now for 18 weeks at a low and high concentration. And it was actually found that the higher concentration was better. And if anyone is wondering, well, like, how do we actually tell our patients to do this? Dr. Patel and her group did a randomized controlled trial demonstrating cost effectiveness of olfactory training with essential oils at uncontrolled concentrations. And so uncontrolled concentration basically just means like you go to the store, you get your bottle of essential oil, that's what you train on. And so they also used either post-infectious or idiopathic patients. They did their upsit at baseline and 6 months, and they were looking for, at least a 10% change. And they had 19 patients in the essential oil group, and 16 were randomized to the blanks. And what they found is that with your essential oil group, they had about a 32% significant improvement versus 16% in the blanks. And they did note that age, duration of loss, both significantly correlated to lack of improvement. My one caution here with essential oils at uncontrolled concentrations is, number one, you want to make sure that you tell your patients that these are just to be smelled. These should not be applied to the nasal mucosa or to any other internal surfaces. And if they are truly anosmic, if they are truly anosmic, they may want to have someone in their household smell whatever the oil says it is and make sure that that's a representative smell. What we've noticed in some of our work is that the essential oils, if they're at a very high concentration, like just straight out of the bottle, there are some scents where you can tell like, oh, there is for sure something here and it is very strong, but can't tell what it is. And so in those cases, it might be worthwhile to have those either put on, a cotton ball or something that to where not as much is delivered, or it can be diluted in a carrier oil. And then this is one of the other papers I alluded to earlier where budesonide irrigation with olfactory training is improved outcomes compared to olfactory training alone. And one of the things that I think is very exciting about olfactory training is that, we know that it leverages the synaptic plasticity inherent within the system, but there are some really smart people, as you see listed as the authors of this paper, who are able to quantify that with functional imaging. And what this figure is illustrating are the overall fMRI results from individuals who were anosmic and underwent 12 weeks of training. And so what you can see is that compared with baseline, which was at the top row there, and then after their 12 weeks of training, which is that bottom row, not only did they significantly improve in terms of objective olfactory function, but there was also modification of functional connections. So, I mean, even someone like me can see that there's more red dots on the bottom versus the top. And so that did represent a statistically and potentially clinically significant increase in connectivity and function with olfactory training. And I love this study because I hate Sudoku. So I've already spoiled the results for you. But there was also a study of olfactory training with older people that was recently published. And what they wanted to compare was olfactory training versus Sudoku for 5 months. And one of the reasons that olfactory training and improving olfaction is becoming a much higher priority in the neurocognitive literature is because we know that olfactory dysfunction oftentimes precedes neurocognitive decline and can be predictive of who is going to have, mild cognitive impairment progress to Alzheimer's. And so since we know that we can improve on olfaction with training, the question is, well, does that by extension then improve long-term cognitive outcomes? And they enrolled 60 patients who did olfactory training versus 31 who did Sudoku. And they did make them bring the Sudoku booklet back with their follow-up appointment so that they couldn't just say like, yeah, I did it, and then not actually do it. And what they found here, which I find truly fascinating, is that olfactory training improved threshold and discrimination scores. So they performed better on objective olfactory tests. It also improved their semantic and categorical verbal fluency. It decreased their depression, and it also decreased their cognitive age. And so I'll leave it at that. And just kind of return to some of the original foundational concepts for the overall talk, which is that olfaction is both primitive and complex. It has implications for a wide variety of conditions. As we noted, regain of function is possible. So I think for your patients that, you know, even with long-standing olfactory dysfunction, if they're willing to try it, olfactory training is a very reasonable option. You know, they're essentially, it's the investment in the odorants and their time to see if they get any improvement. And I think, you know, as we continue to investigate the different ways that olfaction is impacted, whether it's, you know, neurologic disease or, you know, viral diseases like we're seeing now, I think we'll only continue to learn more and more. And if, you know, high viral load in the nasopharynx impact on olfaction, you know, are these things good things, or in terms of neuroprotective, are they bad? Do they represent perhaps new therapeutic options, you know, for truncating the overall severity of the infection, or preventing neurocognitive spread? So I think it's an exciting field. Hopefully you guys have learned something new today, and I'd be happy to take any questions that you might have. And if you need to contact me, there's my contact information. Okay, so I see a question here that says, which olfactory training regimen do you recommend? And do I recommend these in the absence of objective diagnosis? So I'm going to stop sharing if that's okay with you guys. In terms of olfactory training regimen, my answer is twofold. So number one, we have some current olfactory training trials that are ongoing where we're using dilutions of essential oils. So if patients want to enroll in those trials, you know, we enroll them by that mechanism. But alternatively, you know, if they're like, no, I just want to do something at home, I usually will recommend to them those initial 4 scents from Dr. Hummel's work. So the rose, eucalyptus, clove, and lemon. As I mentioned, I do recommend that they make sure that someone with a normal sense of smell vets that those scents do represent what they're supposed to. And then I advise them to do it twice a day for at least 6 months before, you know, really giving up. Sometimes, you know, some of those scents, especially rose, can be very expensive. So alternatively, you know, I think the stimulation is more important than the specific scents. So if they have other essential oils at home or access to other things that they can easily use, those are very reasonable alternatives. To answer the question of, do I recommend these in the absence of objective diagnosis? You know, for me, I test everybody with our methodology in the clinic to get an idea of what their objective olfactory status is. However, I will say that some of the things that we've noticed is that there are some patients who score very poorly in terms of their own subjective rating of their olfaction and the, you know, huge quality of life impact on the QOD, but then we've tested them and we're like, oh, it doesn't seem like your sense of smell is all that bad. You know, so there can be a disconnect between even our objective measures and what they're perceiving. And this is in the absence of people that have some sort of, you know, secondary gain to be had. And so I will still recommend olfactory testing for those, or not testing, olfactory retraining for those individuals as well. One additional comment that I do have, if you have someone who is newly post-virally hyposmic or anosmic, there are a lot of my patients that fall into that category. Sometime within the first year, typically of their olfactory loss, they will develop a persistent bad smell. So for some folks, they describe it to me as either like a wet cigarette or like a wet dog smell that seems to just live in their nose, that nobody else perceives. That usually gets better with time, but I do caution all of my patients about that because I don't want them to think that it's because of the olfactory training. It's something that I see pretty commonly just anecdotally in my practice in those who have had olfaction, olfactory dysfunction long standing and are just now coming for help. They do still remember that wet dog smell early on in the course, or as I follow folks that have newer olfactory dysfunction. Oh, all right, it's like I see another comment here. Oh, Katie, you're welcome. Another episode of the podcast will be posted shortly. All right, any other questions, concerns? So what do I tell my patients with CRS with nasal polyposis in regards to chances of regaining smell? So I usually will, I try to hedge on the side of under promising and hopefully over delivering. I oftentimes will quote them about a 30% chance of, increased sense of smell. And then I will always say, like, I would not offer you a surgery purely to potentially increase your sense of smell. That would be a happy side effect that I would be happy to take credit for. But the overall literature, supports somewhere between potentially a 30 to a 50% chance of increase. And it might not be all the way to, what they recall their baseline being or where they would like to be. Okay, well, I guess I will hop off. I see Dr. Cacarella is logged on, so I don't want to steal any time from him because I know his lectures are always great. But yeah, if anybody needs to contact me, feel free to email, or if you want me to send you any of those papers, etc., I would be happy to.
Thank you so much for being here today.